Good morning. I'm Raj Dave at C3 2018 in Orlando, Florida. And I have two distinguished guests with me today, Dr. Takashi Akasaka, Professor of Medicine from Wakayama University in Japan. Welcome, Dr. Akasaka, to the meeting. And I have Dr. Antonis Karanassos from Hippocratios in Athens, Greece. So we had a fantastic session on PCI optimization yesterday, specifically designed course for international physicians. As we have really reached the plateau in the innovation and development of drug-eluting stents, PCI optimization has really become a new frontier, because in order for us to achieve better patient outcome after coronary PCI, we need to optimize the PCI procedure. So how we do that is by doing physiological testing and by optimizing the imaging and the stent deployment and achieving complete and optimal revascularization for these patients. So Dr. Akasaka is a world leader in OCT, and we had a lot of discussion about OCT yesterday. So let me ask a couple of questions,
Yes.
Dr. Akasaka. First of all, in your center, how many percentage of patients get OCT with a coronary PCI?
Nearly 70 to 80% we use an OCT guided PCI, and residual 20 to 30% we use an IVAS. So anyway, we try to use an coronary imaging at the time of PCI.
I see. So, that is, quite an astounding, numbers of patients who are getting an imaging procedure. Is this pretty common across the Japan to have very high number of imaging for
Yes.
coronary PCI?
Yes, we have a long history of an IVAS guided PCI, more than 15 years. At the moment, imaging guided PCI in daily clinical practice in Japan might be 90% cases. And the ratio of IVAS and OCT, it's depend on the institution. Yeah.
I see. How about your hospital in Greece?
Well, I think that our percentage is quite lower. This is around 10 to 15%, and this is mainly due to reimbursement issues, so we really cannot afford to use it in more cases.
Yeah. So I think that in US, if you look at it, it's about 20-30% penetration. And there are multiple issues, including reimbursement time, and sometimes the lack of training to interpret the images and do appropriate testing. So we talked, Dr. Akasaka, we talked a lot about physiological testing yesterday.
Yes.
And there are multiple outcome trials which were mentioned. Mm-hmm. How many percentage of patients in your hospital gets an FFR and then also gets an OCT or IVAS?
I see. FFR might be nearly 50 to 60% because we sometimes use an perfusion image before admission, right? And the result is very clear. We don't use an FFR at that time. However, if there are multivessel disease and one lesion is significant and also documented by perfusion image, we try to use an OCT to identify the other lesion, whether it is significant or not. Right.
Right. So one of the issues that is being discussed a lot now is that post PCI FFR also correlates with the outcome.
Yes.
So if you are doing in a patient an FFR before the procedure, and then you do a PCI with an imaging device,
Right.
do you think that there is a need for now a post PCI FFR if you had already done an OCT?
Yes, FFR is another index to predict the patient prognosis. I agree, but FFR cannot demonstrate an incomplete apposition or malapposition. So it's depend on a case. So we need both, if possible, but it's depend on the reimbursement and the medical cost.
Yeah.
Yeah.
So in our institution, we do a fair amount of patients where they have an FFR first, followed by OCT.
Yes.
But then if I already have OCT image and if I've optimized the stent, then I will not do a FFR afterwards because I've optimized the stent result already.
I see. Yeah.
What is your practice?
Well, in our practice, we rarely use both modalities. We usually use non-invasive testing in order to identify ischemia. And then if we have doubt about the lesion, then we also do an anatomical assessment by OCT. So we do have the physiological information non-invasively and then try to pinpoint the stenosis by using the OCT. And after stenting, we use OCT in order to see if we do have an optimal result. And if we have an optimal result, then I do not think that we have a need for a further confirmation.
Yeah, so we can certainly use OCT for need for revascularization because OCT FFR correlation has been documented.
Yeah.
And if the MLA on the OCT, at least in LAD distribution, is less than 1.97, then it should correlate with the physiology.
Yeah, I agree.
So that is one method of evaluating the patient as well. So it is acceptable. Let's talk briefly about some of the nuances with the new OCT software. I'm personally familiar with the iLumen Optis system from Abbott, which is the system that we have in our lab. And you also have that system in your lab, so does Antonis. And there is an Terumo system available as well.
Yeah.
But iLumen Optis software has substantial other functionalities such as 3D rendering. And this issue did come up yesterday that at least in patients with bifurcation, and Antonis and you both showed several examples of this, that a bifurcation 3D imaging can potentially be very useful for bifurcation carina optimization.
Yes.
So how easy it is to produce a 3D image?
Yeah, the 3D is very useful, as you said, and it's quite easy to get the 3D. Just put a button, we can get a 3D image within 2-3 seconds, right? So it's nearly the real-time image. So we can identify the incomplete apposition or under expansion automatically by using old measurement system and the wonderful display, color display of 3D. It's quite easy to identify the stent condition. Very easy, yeah.
Also the wire entry of the side branch.
Yes.
That can be useful too. Now it is sometimes difficult to see, because the software sometimes does not recognize both wires.
Right.
But most of the cases it's pretty useful to get that done. You have done, Antonis, a lot of research work on bioresorbable stents and the follow-up of the BRS with OCT, and you have talked a lot about stent optimization in your talk yesterday. So can you tell us some important things that a operator should look for to how to optimize the stent in an OCT?
Yes. So it's important that we do have OCT today that has an established clinical indication for procedural guidance. It's quite clear in the cases of stent failure, but it can also be quite useful in cases where we have some more complex lesions, and then we can actually define the landing zone, and also for bifurcations, we can use it in order to define our strategy. And of course, we can always check the result, see if we do have an optimal expansion, if the entire lesion has been covered, if we have any extensive malapposition, and do whatever is necessary to correct these.
Yeah. So to summarize the discussion, the physiological testing is important. Optimization of the stent result with OCT or other imaging modalities is also critical, as in order for us to get to the next level after the innovation in the drug-eluting stents, we really need to go to a PCI optimization concept. So thank you very much, gentlemen, for your wonderful insight into this very complex subject. And we will continue to talk about it during the C3 meeting in Orlando. And welcome again to beautiful Orlando City.
Thank you.
Thank you.